and is our newest assistant professor in medical oncology, building up his practice. So while Mike was at Johns Hopkins, he really pioneered, along with other investigators, a very innovative way of thinking about treating advanced prostate cancer. So most of you are well aware that our usual approach is suppressing androgen and suppressing testosterone signaling. So this idea really flips that on its head. Mike?
All right, thanks, Pete. So I wanted to talk a little bit about some work that I did when I was wrapping up my training at Hopkins, again, looking at testosterone as a way to actually treat advanced prostate cancer. And then I'll talk a little bit about some ongoing work that's being done out at Hopkins and some projects that we're going to get involved with out here as well. So before I get into the meat of things, I did want to just briefly review sort of simplified prostate cancer biology. I think it's important for us all to be on the same page. So the conventional wisdom is that androgens, the one that most people have heard of, testosterone, fuel prostate cancer by basically migrating into the prostate cancer cell where they bind to the androgen receptor. This complex then migrates into the nucleus where it binds to DNA, and that signals a cascade of events that basically lead to the prostate cancer growing, proliferating, and causing all the bad things that happen when somebody has prostate cancer. Now, this signaling pathway from androgens to receptor to nucleus is really the main target of how we treat advanced prostate cancer, and it has been for many decades now. The first thing that we typically do when we meet a new patient who has advanced prostate cancer is we put them on androgen deprivation therapy like Lupron. And this basically lowers the amount of testosterone or androgens in circulation to a low level so that there's not as much androgen present to actually bind with this receptor. This works for most guys only for a finite period of time, and at which point, after the Lupron stops working by itself, we say somebody's progressed to a state of castration-resistant prostate cancer. Now, just because Lupron's not working doesn't mean we give up on trying to inhibit this signaling pathway altogether. But recently, we've developed a number of new drugs that are able to really inhibit this pathway even more effectively than Lupron alone. So drugs like abiraterone or Zytiga work by lowering androgen levels even lower to almost zero. And then drugs like enzalutamide really work by blocking the ability of androgens to bind to this receptor. So we have these tools now that we're able to basically almost completely inhibit this signaling pathway, and that's really the mainstay of how we treat advanced prostate cancer, from sort of initial diagnosis to this castration-resistant form of the disease. But the real problem is that in spite of almost completely being able to inhibit androgen signaling, advanced prostate cancer still progresses for most guys. Prostate cancer is adaptable, and resistance almost always develops. So I think that one of the major challenges that we have as a community of physicians and scientists that treat prostate cancer is really figuring out how do we target this adaptive response? How do we come up with drugs that are effective for the most resistant forms of prostate cancer? And to that end, I think it's important that we really understand the biology behind why resistance emerges if we're going to ultimately develop drugs that can target it. So one of the most frequently occurring events that we see in men with castration-resistant prostate cancer, men that have been on drugs like Lupron for a long, long time, is that prostate cancer cells will upregulate the amount of androgen receptor that they have within them. So this increase in androgen receptor basically means that there's more androgen receptors floating around. So even if there's only a very low level of androgens, they're able to scavenge up whatever's available and use that as fuel to drive its growth. What's interesting is that we've known for many years now that when you take prostate cancer cells and you grow them in low androgen conditions for a long time, and then you suddenly change them into a high testosterone condition, so you take cells which are growing in spite of no androgen whatsoever, so pretty similar to what you'd see in a guy with castration-resistant prostate cancer, and you suddenly flood them with androgen like testosterone or other forms of androgens, you actually see that a lot of those cells end up dying. And we've known this for many years, but just recently we've started to learn why this might be. And there's a couple of mechanisms that some of my collaborators at Hopkins have really sort of teased out for why this might be the case. One is that these high doses of testosterone, when given to these cells that are adapted to living in low testosterone state, can lead to DNA breaks, so it can basically cut the DNA in half. It can also interfere with the ability of DNA to replicate. And these are two processes which are really essential to prostate cancer cell survival. So when you interfere with those, the cells die, which is really the goal of any prostate cancer treatment. And so we wanted to sort of take what we had learned and move this into the clinic. So we developed a form of testosterone therapy that we call bipolar androgen therapy, or BAT for short. And the way that this works is that we take guys who have been chronically on drugs like Lupron, so they're the ones who likely have high levels of androgen receptor, and then we put them through monthly injections of high-dose testosterone. So they get an injection on the first day of the month, and we see their testosterone levels spike sky high, way higher than you'd expect in a normal, healthy guy. And then over the preceding month, we see that the testosterone levels start to gradually drop. They get close to sort of being in that low castrate range that you get with Lupron alone. They don't quite get there, but it's close. And then at that point, we recycle it again, and we give them another injection of testosterone. And the idea is that you're going to kill off cells which have adapted to a low testosterone state, and because we're not keeping them at this high testosterone state for too long, you don't allow them to adapt to grow in that condition either. So it's sort of staying one step ahead of the cell's natural ability to adapt to any one condition. And so we wanted to test this formally in a study. So we launched a small pilot trial, and this slide's a little busy, but it kind of outlines how we ran this study, so I'll go through it briefly. We enrolled men who had castration-resistant prostate cancer. Again, these are the guys that we would guess have a high level of androgen receptor, the ones that we think are going to respond best to this form of treatment. And we treated them with a combination of testosterone plus an oral chemotherapy pill called etoposide. And the reason we used etoposide is because there was some evidence that this could help enhance the ability of testosterone to cause DNA damage. And we treated them with the combination for 3 months. After that 3-month period, if we saw that PSAs were going down, we let them continue on testosterone alone. Again, monthly injections. If it looked like the PSA was rising, they came off the study. And in this trial, we really targeted guys that had no symptoms from prostate cancer, no pain, no major issues where we were afraid that they weren't going to be able to urinate if their prostate cancer got worse. Guys that didn't have bulky cancer on scans, and the reason was because we were nervous that if this didn't work, it could potentially cause some harm. So we wanted to do everything we could to limit the chance that we were going to cause harm for patients. So the results of this study, so again, it was small. We only enrolled 16 men, and only 14 of them actually completed the initial 3 months of therapy. One guy developed priapism, which is a sustained erection over 4 hours. So that was after the first testosterone injection, and he came off study in spite of his request to remain on it. I think he's doing okay otherwise. The other guy actually, the etoposide, the chemo pill, actually wiped out his immune system, and he developed an infection that actually led to his death. So that was something that was clearly not related to the testosterone, but at the end, that was the reason only 14 out of 16 completed the initial 3 months. But so out of those 14 guys that actually were able to complete the first 3 months of therapy, we saw 7 of them had their PSA actually drop to a lower level compared to when they first entered the study, which is kind of surprising because usually testosterone causes PSA levels to go up, and we saw half of these guys had their PSA levels drop. And then 10 patients on the study actually had tumors that we could measure with a CAT scan, and half of those guys had their tumor shrink as well. So this is just a plot of one individual who enrolled in the study's PSA over time. And you can see that on the left-hand side, he's basically received a lot of the sort of hormonal therapies that we typically use for guys with castration-resistant prostate cancer. So enzalutamide, abiraterone, and then ketoconazole, which is sort of like an older, dirtier form of abiraterone. And throughout this process, he has sort of transient dips in his PSA, but it does progressively increase. And when he came to us to enroll in this study, his PSA was over 800. And then he had a really nice response. After the first injection of testosterone, PSA basically plummeted down to almost 0, and he was on study for, I think, close to a year. Here are just 2 representative CAT scans from guys that had tumor shrinkages on study. So the top 2 pictures basically show, you can see it's circled in red, that 2 tumors, thanks. So you can see that he has 2 tumors basically circled in red here, and then after 3 months, they're more or less gone. And this guy had what we would call a complete response to therapy after just 3 months. The guy on the bottom, he's got a pretty large tumor in his pelvis, another smaller one right here, and he had a really dramatic reduction in size, so he had a partial response. But overall, he was another guy that did pretty well on the study. And again, there were 3 other people that had responses radiographically, things that we could see it shrinking on scans. So what about side effects? Most were really not that severe. Guys tolerated this quite well. In general, they felt better than they did before they started the treatment. Energy went up, libido came back. In general, most of the guys really enjoyed being on the trial and felt wonderful. The side effects that we did see were probably mostly related to the etoposide, the chemotherapy pill. Again, there was that gentleman that developed that life-threatening infection. Regarding side effects that might have been due to the testosterone, we saw swelling in one guy out of the 17 enrolled, the episode of priapism that I mentioned. And then there were 2 guys that had asymptomatic blood clots in their lungs. So they didn't have any symptoms. We wouldn't have done a scan except for the fact that they were on a trial. And when we did it, we saw that 2 men had very small blood clots. Whether or not these are due to testosterone or not, we don't know, but we put it up there just because there's the possibility and people should be aware of that. I think importantly, though, no one on the study developed pain. Again, people generally felt quite well. There was no evidence that this made the cancer worse, that it flared up after getting testosterone therapy. And I think one of the more interesting things that we observed on the study was that there may be this ability of testosterone to actually resensitize patients to hormonal therapies. So in 12 patients who were treated on the study and subsequently came off, we allowed their testosterone level to fall back down to the castrate range, the range you typically would see for a guy who's on Lupron by itself. And in 9 out of those 12 patients, we saw that their PSAs actually started to decline after letting their testosterone levels fall. And this is surprising because everybody enrolled on the study basically had a progressively increasing PSA just on drugs like Lupron prior to enrolling. So we would expect that nobody would have a PSA decline at this point, but we saw most of the men actually had their PSA drop just from allowing their testosterone to fall again. In 10 patients, we allowed them to go on to receive a second-line hormonal therapy. So this would be drugs like Casodex or enzalutamide or abiraterone, drugs that you use after Lupron. And in all 10 of those guys, we saw PSA declines. That's 100% of the patients had a PSA decline. And typically, at this stage of the disease, we don't expect that high of percentage of patients to actually respond to these types of drugs because we've already been hitting that one signaling pathway with everything we got prior to this. So there tends to be a lot of resistance to drugs that target that pathway. And then in 3 patients, we actually re-challenged them with the exact same drug that they had progressed on previously. So in 2 people, it was Casodex, and in 1 person, it was enzalutamide. So for instance, the guy on enzalutamide was progressing on enzalutamide. He went on BAT therapy. When he progressed on BAT, he went back on enzalutamide, and his PSA dropped on enzalutamide. So it sort of gave us a sense that maybe there was something going on here where testosterone was able to resensitize these guys to drugs that they had already progressed on. And this is just an example of a guy who had a nice response on trial. This is before he enrolled. You see his PSA is rising. He goes on testosterone injections, and you can see a little blip in his PSA for the first couple of injections. But after that, those first 3, you can see that the PSA actually drops and stays low for a number of months. When it did eventually progress, we took him off study and allowed his testosterone level to come back down to normal again. And surprisingly to us, his PSA actually fell and dropped to almost undetectable just with allowing the Lupron to sort of do what it does again. So there are a lot of questions remaining. This was a small study, and it was by no means definitive regarding the role that testosterone may play in treating patients with castrate-resistant prostate cancer. We still have to figure out why only some of the men respond. And then I think that one of the questions that we're trying to answer is if there is this resensitization effect, what underlies it? Why is this happening? We need to understand why it happens if we're going to figure out how we can sort of incorporate this into our current treatment paradigm. And then also I think it's important to really figure out who's most likely to respond because that's going to ultimately help us avoid giving it to a patient who could potentially have a flare reaction. Testosterone still has the potential to cause disease to get worse if it's given to the wrong patient. And case series from many decades ago show that when we try giving testosterone back, there are some men that have bad untoward effects. So I think we still need to understand how it works better. And so briefly, a couple of ongoing studies which are sort of trying to get to the bottom of some of these questions. This is one that's at Hopkins only. It's called the RESTORE study. And it's really designed to answer the question of resensitization. So men who enroll can either have progressed on abiraterone or enzalutamide. After they enroll, everybody gets BAT therapy, testosterone. And then after they progress on BAT therapy, they go on to whichever drug they'd already progressed on. So for the guy on top, for instance, he would get abiraterone, testosterone, and then abiraterone again. And this will allow us to see if he's been resensitized, if he has a response to the abiraterone by itself.